Thank you so much, Dr. Meena. Indeed, it's a pleasure to be part of this course. And at the outset, I will thank Dr. Arup sir for allowing me for this presentation. So, just now, I was allotted this topic of epidemiology and standard presurgical and perisurgical infection prophylaxis. So whenever we have endophthalmitis, it is one of the dreaded complications after any intraocular procedure of which we all are scared of. So let's see the epidemiology. Once we talk about US, it is 0.04% of cataract surgeries and 0.016% of patients receiving an intravitreal injection. When we talk of England, it is 63% of cases which are associated with intravitreal injections, and while cataract surgery accounts for 17% of cases. Now in Asian countries, the epidemiology is slightly more. Reported incidence is 0.023% to 0.076% in post-cataract cases, and varies from 0.01% to 1% in post-intravitreal infections. Let's see of our own country. Now because of introduction of intracameral antibiotics, the incidence is now low, 0.02% to 0.15%, and it is increased with combined procedures like vitrectomy or pars plana vitrectomy. Secondary IL implantation seems to be at higher risk, and trabeculectomy even much more incidence of endophthalmitis. When we talk about different types of intravitreal anti-VEGF injections, it is similar. So let's see how does this happen, then only we can manage this particular situation or prevent it. Source of infection is gram-positive bacteria, especially coagulase negative staph. Major periocular reservoirs are eyelid, lashes and conjunctiva. And bacteria can enter the eye from multiple other sources also, like aerosolized bacteria, contamination of various consumables, etc. So what should we do? So there are multiple guidelines and reviews available. Two of these systemic reviews, which were actually very good and with practical implications, I have incorporated. Now this was a clinical guidelines published between 2008 to 2023. They scanned 110 articles, 431 articles were screened, out of which 20 eligible studies were set for data extraction. Now this is the just this month published article from our own country in American Journal of Ophthalmology, which highlights various consensus guidelines and very practical article. So on the basis of these articles, let's see what all we need to do. If you see a patient like this, with eyelids like this, we have to maintain the lid hygiene and disease management, never jump for surgery in these patients. Treat blepharitis, do lid scrubs, warm compresses, topical antibiotics like azithromycin, oral doxycycline. Manage acute and chronic dicryocystitis, avoid any concomitant procedure with cataract surgery, and check for any infective foci. It might be an abscess, it might be a dental infection, and then of course control systemic diseases like diabetes and anemia. Now, once we talk about preoperative antibiotic prophylaxis, of course, it reduces the bacterial load of conjunctiva, but the strong evidence to support its efficacy is actually lacking. When we talk about ASCRS survey, 90% they use topical antibiotics, but recent guidelines say that 3 days preoperative antibiotic offers superior efficacy compared to shorter duration of 1 day or 1 hour. So preoperative topical antibiotics is used everywhere worldwide, and we also use it. Let's talk about skin and surface antisepsis. Now this is very critical preventive strategy to use antiseptics before interventional eye procedure. Application of any type of antiseptic, it might be povidone iodine, it might be chlorhexidine, reduces the incidence of infection. Almost all guidelines, they recommend conjunctival sac installation of 5% povidone iodine. But the question is, for how long? And on that basis, AIOS guidelines, they say that application of povidone iodine 10% on skin and 5% in conjunctival cul-de-sac for 3 minutes is adequate and supports strong evidence. So if there is allergy to iodine, then we can resort to 0.05% of aqueous chlorhexidine. So thus we are preventing infection without encouraging antibiotic resistance. Surgical draping is extremely important. Initially the lashes were cut, but now the recommendations are not. So you have to cover all the eyelid margin and lashes with the help of your eye drape. If it is a pre-cut drape, it is okay, otherwise you can do it yourself. And make sure that all the lid margin and eyelashes are properly covered underneath the eye drape. This is an important and mandatory step to pursue. Now, what about consumables during surgery? So, topical anesthetic eye drops. Be very, very careful. In every OT, please open a new vial of any anesthetic eye drops. Never use a drop which has been previously opened. Surgical blades, new for every case. Autoclaving instruments in between. So, use flash autoclave or have multiple sets. Phaco-tip and bimanual, if you can change, it is extremely good. Now, this is an article from British Journal of Ophthalmology, published in 2025 only, and gives very good practical tips, done on 85,000 of sequential cataract surgery. What they did, they divided into two groups, 1 and 2. In group 2, they gowned each patient, they changed the surgical gloves, they changed OR floors and counted after every patient, and only one patient at a time in OR. And the other set of group 1 patient, in those patients, all these processes was not done, although the gloves were sterilized, but they were not changed. So what they concluded is that adopting these 4 set of temporary OR protocol is often not mandatory in Western world and did not reduce the incidence of post-operative endophthalmitis. So the practical tip is very good about this article. Now coming to another very important and pertinent topic, which is intracameral antibiotic prophylaxis. According to 2014 ESCRS survey, intracameral cefuroxime reduces the risk markedly as compared to topical therapy alone. And 74% of respondents, they regularly employed intracameral antibiotic prophylaxis. And most of the guidelines they suggest. Now, what about other antibiotics? Because cefuroxime is not available in our country. This article highlights very good about other antibiotics, which took 51 eligible original articles, and they said that intracameral injection of vancomycin, cefazolin, cefuroxime and moxifloxacin, they all are equally good and they prevent post-operative infection. So the evidence from our own country by Dr. Haripriya et al. Say in more than 6 million of cases that there was reduction of significant endophthalmitis with intracameral moxifloxacin use, and because the MIC achieved its 10 times, and therefore it remains bactericidal for much longer duration of time than cefuroxime. Moreover, it is available in our country also, and subsequently ASCRS issued a clinical advisory on intracameral moxifloxacin in 23 and recommended a dose of 0.5 milligram achievable by using 0.1 ml of solution. So this was the graph from Dr. Haripriya et al. Study. Finally, I would say wound closure is extremely important. Watertight wound closure is the crux. We don't want any hypotenuse eye in which the water seeps in from outside inside the eye. In case you are doing some complicated case and you are unable to hydrate the wound, never forget to put one suture. It is always good. And after completion of surgery, when we talk about immediate antibiotic eye drops, there are no fixed guideline, although certain areas fluoroquinolones are the choice of drug. But post-operative, after 4 to 6 hours, when there is waning effect of intracameral antibiotic, don't forget to start the antibiotic eye drops. So what is the duration in post-operative period? It might vary 1 week, 2 weeks or 4 weeks depending on your geographical area. But antibiotics should never be tapered to avoid any resistance. So the basic factors we need to take care about: instrument sterilization, operation theater should be fumigated, the airflow, OT, temperature, humidity should be monitored. So the take-home message is that intracameral antibiotics are most reliable to prevent endophthalmitis. Long-standing role, highest quality evidence favor povidone iodine 5% in the conjunctival cul-de-sac. Watertight wound hydration is extremely important, and post-operative antibiotics should be instilled, although they have moderate evidence for the benefit. Thank you so much for your kind attention.